Thank you so much. السلام عليكم ورحمة الله وبركاته. كيف حالكم جميعا؟ أنا دكتور محمد عقوري. In this presentation, I'm going to talk about updates on sepsis management. Before I start my presentation, I want to take the opportunity to thank the organizing committee, the panel of experts and moderators, speakers, and the audience, and thank you so much for having me today. So our lecture today regarding the updates of sepsis management is actually, it doesn't need to be a lecture on sepsis, so this is not a formal lecture on sepsis. You don't expect me to start from the pathophysiology to the management of sepsis. This needs more time. I'm not gonna do that in 25 minutes. So it's meant for people who know what sepsis and they know how to manage sepsis basically, and then they need more update. So these are just important words to start with. So my objectives today, I'm gonna give updates about surviving sepsis campaign, history of this organization, an overview about the updates 2021, and then the recommendation and what's new and what was changed from 2016. And finally, we'll have summary of recommendations and we'll answer questions. Let me start first with history and perspective of what's known as surviving sepsis campaign. So surviving sepsis campaign is an organization with collaboration between European Society of Intensive Care Medicine and Society of Critical Care Medicine, the American Society, and many other organizations. It was launched in 2002. What's known as Barcelona Declaration. And since then, they started issuing guidelines. They have come up with 5 guidelines starting from 2004 and then updated 2008, 2012, 2016 was the latest, or the last one, and the latest one was the last year, the end of the last year, 2021. So every time these guidelines got bigger and bigger, and in 2020, they come up with pediatric sepsis. They select them from the main guidelines and the COVID-19 guidelines. The aim of this organization, the Surviving Sepsis Campaign, is to reduce mortality from sepsis and increase awareness regarding sepsis. Before I move to the next slide, I just want to stress on one point. So sepsis is the intensive care, is the ICU equivalent of STEMI in CCU. So in STEMI, we usually say, we usually tell our student that minutes means muscles, and you need to start as early as possible in your treatment, either PCI or thrombolysis. And also, the case is not much different from sepsis, and even worse. And every minute passes on patient with sepsis is going to cost life again. So the mindset for managing sepsis should be the same mindset for managing STEMI. If this is the only message that you got from my presentation today, I would be more than happy for that. So Surviving Sepsis Campaign guidelines. So the guidelines is the main focus of our lecture today. And as I said, so in my presentation, the panel of the Surviving Sepsis Campaign, the panel of experts, they have 93 statements or recommendations. And in every statement, you're gonna, read like we recommend or we suggest. We recommend that if you read we recommend, that means the patient the evidence is strong evidence. If we say, for example, the panel say we suggest, so that means the evidence is weak. And what does that mean? If we say we recommend, that means the evidence is strong, and most of the clinician and 95% of clinicians are expected to adopt this recommendation, and it can be used in like performance quality measure. And if we say weak means that needs to have like clinical judgment and needs a shared decision making, and can be adopted usually by more than 2/3 of the clinicians. If the panel said no recommendation, that means there is no evidence. They couldn't draw any conclusion about the recommendation.
I was just saying.
Sorry, there is an okay. So overview of the surviving sepsis campaign guidelines statements. So I'm going to talk about 93 recommendations. As you can see in the pie chart, most of the recommendations are weak. So weak recommendations. Do you see the slides? Do you see my slides?
Yes, we are.
Okay. So the pie chart on the right side show that the recommendation, mostly more than half of recommendation is weak recommendations, and 1/3 of recommendation is strong and best practice, and no recommendation about 10%. So that means we need more and more studies and RCTs regarding sepsis practice. And on the left side, you can see these are the 6 main areas that I'm gonna talk about. The first is screening and resuscitation, which is the stepwise management of sepsis. And there is a recommendation regarding the infection, the hemodynamics, the ventilation. And there's a whole new section, which is the goals of care and long-term outcome. This is very new section in this update. It hasn't been there in the last guidelines in 2016. The reason why they included this section, because many patients survived sepsis and they are like dealing with the poor outcome and quality of life and the aftermaths of sepsis. Additional therapy is going to be like these things that ED and ICU management that can be incorporated into management of sepsis, like feeding, like DVT prophylaxis, and these kind of things. So let me start with the recommendations. First of the 6 areas is a screening and resuscitation. So I'm going to talk about the things that changed, or the things that are new to the recommendation and different from the last guidelines in 2016. So in this area, screening and resuscitation, we have 2 new recommendations and 1 change. I'm going to go for the next one. So this is the first, and I think this is one of the biggest things all we have to know. The panel recommend against using Q-SOFA. So Q-SOFA is not recommended. So they said strong evidence. For those who need to refresh their memories regarding Q-SOFA. So Q-SOFA has been, started in use in 2016. They come up with the Q-SOFA in the last guidelines, and they said it's important and it should be used in the screening and assessment of mortality of patient with sepsis. And then there was like practicing the SOFA score, which is the main SOFA was very long and needs blood labs. And then they come up with the short version, which is the 3 points. The Q-SOFA is like tachypnea, altered mentation, and systolic blood pressure less than 100. So the problem with the Q-SOFA, the reason why the panel felt like this should not be used as a standalone way of screening sepsis, because screening tests, we need high sensitivity to rule out, things. So Q-SOFA has poor sensitivity, and this is the main reason. And it has like not the great specificity, but it's moderate specificity. So that's why it is not completely removed, but you can't use it alone. When you compare Q-SOFA with SIRS, which is already in use, SIRS has more sensitivity, and SIRS perform better than Q-SOFA in terms of sensitivity. And the other two scores, which is the NEWS score and the MUSE score, these are again a great way of screening sepsis. There is no preference of anyone over the others, but the take home message is that Q-SOFA cannot be used alone. This is very important change, which is a strong recommendation. So this is again my talk about which is explaining why Q-SOFA has been like downgraded or recommended against. The other statement as compared with the 2016. So in 2016, you can see at the bottom of the slide, we recommend that initial resuscitation of fluid 30 ml per kg. So when we receive people with sepsis, we know that people with sepsis, they definitely need fluid. But the question always, what is the amount of fluid needed in the initial resuscitation, and what's the amount of fluid needed in the first 24 hours? And this has always been a question, and it's been debatable, and it remains to be a question, to be honest. And the panel was very conservative. So you see in 2016 was we recommend, and in 2021, they said we suggest. So they just downgraded the comment and recommendation from strong to low evidence. And the reason why they did that. So let me go back in the historical context that brought the 30 ml per kg approach. So in 2016, the panel reviewed certain studies, but there is no trial which tested the fluid volume. So they draw the evidence from indirect, reading of these studies. So at the beginning, in 2004, 2008, 2012, there are the RIVER study, and there was what's known as the irrigold-directed therapy, which is a bundle of actions like giving IV fluid, giving antibiotics, CV pressure, mixed venous insulin. And then in 2016, there are 3 studies like PROMISE, PROCESS, and ARISE. These 3 studies in Europe in 2014, 2015, the panel revised these studies, and they did something called Prism Analysis, which is Prism meta-analysis. So they find out that the patient, like you say in the table, illegal-directed therapy and the usual care, both of them already taking about 30 ml per kg, and that was one of the points. They assumed that people with sepsis, they gonna need by default a 30 ml. So that wasn't an evidence-based statement, and that was the reason why they downgraded from we recommend to the weak recommendation. And on the right side, there's another study which is in West California, which is again indirect evidence the panel used in 2016 in order to recommend for giving the 30 ml. This study was applying the sepsis bundle, and they give people with intermediate lactate from 2 to 4, 30 ml per kg. And this study showed a mortality benefit, and that's why the panel felt like there is an indirect evidence for using fluids, which is a 30 ml per kg. But now, after this change from recommend to suggest, I would say, if I receive patient in the ED, I would give him 500 boluses, and if the patient has very low ejection fraction, for example, less than 30, I would start with 250 ml and reassess. And the assessment, there's the fluid responsiveness. Again, this is another area of debate. We need to know how to do the dynamic test for the fluid responsiveness. This is another area of kind of debate. I'm not gonna touch on this in this talk, but you need to give and assess your patient from the beginning, rather than just give the 30 ml per kg. For example, if patient 70 kg, you're gonna give him more than 2 liters straight away. This is, I think, not like a good practice anymore. The other recommendation, they suggest guiding the resuscitation by using lactate over not using lactate. And this is not a big change. We know that lactate is used. So we usually receive people with high lactate, and lactate is a mortality indicator. High lactate at the presentation is associated with poor outcome. And they also recommended the use of capillary refill time, which is the clinical test. So both of them. They studied different studies regarding lactate and regarding the capillary refill time. There is an Andromeda shock trial, which is compared using peripheral perfusion and serum lactate. One thing regarding lactate cannot be used to rule in or rule out sepsis. This is one point. Second, some people with lactate, you give fluid resuscitate. Some people, the lactate is not corrected and it remained high. That, again, one of the things that make lactate is not that the appropriate, and I should say the ideal way of assessing the response. But again, in the clinical context, using other parameters, you can use lactate, and lactate might not respond if lactate doesn't respond. For example, patient presented to me with lactate of 6, I gave fluids, patient improved clinically, lactate still not improving, or even the blood pressure, again, not improving. At this point, I wanna just think about why lactate is not responding, and bowel ischemia need to be excluded, liver disease again, and other causes of type 2 lactic acidosis. I will move to the next section, which is the infection. And we know infection, we are giving antimicrobial, especially antibiotics. And the recommendation from 2016 is to give antibiotics within the first hour. This is the biggest point in sepsis, and the only thing that improved mortality evidence-wise and evidence-based wise is by giving antibiotic so early. So if you delay the antibiotic beyond 1 hour, you're gonna have incremental increase in mortality, which might reach up to 50%, and that's why early resuscitation is very, very important, and antibiotic, again, one of the most important. So this is the thing. The updates regarding the antibiotics in this guidelines 2021, they relaxed in a certain context, they relaxed the time up to 3 hours. So the thing is, they find sometimes we receive patient with sepsis, and you're gonna ask the question, is this patient septic? Or the sepsis, there are many differential diagnoses for sepsis, and you are not sure this patient septic or not. And there are several instances where sepsis diagnosis is like a diagnostic difficulty, and at this point they give you an option, but again they gauge the two. They put two things: is the patient in shock or not? Are you sure, are you certain the patient have sepsis or not? So if the patient in shock, go straight away and give antibiotics. The only thing that they extended the amount of time to 3 hours, the only situation is that if the patient is not in shock and you are not certain that the patient has sepsis. So if the sepsis is unlikely and the patient is not in shock, you can extend, you have a window of 3 hours in order to assist this patient. If you compare this with the 2016 at the bottom of the slide, they said we recommend, and it is 1 hour. So the new thing, so in patient who has no shock and in patient in whom you are not certain of sepsis, you can extend the time to 3 hours. The other thing is when we are gonna stop the antibiotics, again, this is re-evaluate your patient, and there is no strong strong ground on giving any recommendation on that. Again, the others is the hemodynamics. So what changed? The fluid type. They have recommendation regarding fluid type. They have a recommendation about vasopressors. I'm gonna go more quickly because we are running out of time. So we know that a crystalloid is better than colloids, and that's something we already know about. But the new thing, they suggest balanced crystalloid, which is ringer lactate or lactated ringer, instead of normal saline. And this is weak recommendation, is not a strong one. Again, this hasn't changed much from the 2016, because they said either balanced crystalloid or saline. But in this, they suggested crystalloid. Again, this is weak. They based that on different studies. One of the most study is a SMART trial. You can go back and read about the SMART trial. And there is another study, which is BASICS trial, which contradict this recommendation. But the problem, the outcome of the BASICS trial came out after the panel has already convened and met, and they published these guidelines. So in the future guidelines, BASICS trial is gonna change this recommendation. And again, I think in a clinical practice, this recommendation is very important. They suggest using vasopressors, noradrenaline, for shock in a peripheral vein. So we all know that the classic teaching that vasopressor, noradrenaline especially, has to be given in a central line, but that's gonna cost us delay in initiation of vasopressors. So the panel said we suggest starting noradrenaline in peripheral line as far as it's a proximal vein and a large vein, and the time does not exceed 6 hours. So you try just to give it, and try to in the meantime try to plan your management ahead. So that, again, based on many randomized controls trials, because they find low complication rate, faster rate of shock resolution. To be honest, we use this practice before even in the UK and in the US. When I came practicing in this hospital, we used noradrenaline and peripheral lines before the recommendation from this study, and we found it very effective. So if you feel like the patient is very sick and he is in shock, so make the decision of inserting central line quickly, but some patient might get out of shock and you don't need to put any central line. Ventilation is not like this is an ICU management. I'm gonna skip this. We're talking about ED things. Again, there is a new recommendation about ECMO. One big thing I want to finish with is the IV corticosteroid. I think this is one of the biggest debate. It's been back and forth, very large number of studies regarding the use of IV corticosteroid in sepsis, in refractory septic shock. So I'm gonna give a very brief description on this. So the panel suggests, which is very important, In 2016, they suggest against, but in here, in 2021, they suggest giving IV corticosteroid. One point is, it's not in septic shock, it's in refractory septic shock. And what I mean by refractory septic shock, if you, for example, treat patient, you give the initial resuscitation, patient in the ICU is on 2 vasopressors. So for example, you will start in norepinephrine. We use a dose of from 0.01 to 0.5 microgram per kg per minute. So if your patient gonna have more than 0.2 of NORAD, and the second vasopressor will be, according to the guideline, Vasopressin. If you add Vasopressin and you are gonna, the infusion rate of norepinephrine more than 0.2, that's the time you start corticosteroids, and it's 50 milligrams every 6 hours. So this is the recommendation, which is 200 milligram a day. These are the studies. There are many studies, but the biggest one is the Adrenal Study, which in 2017, again, steroids has no effect on mortality. This is very important. That's why the panel was very conservative in their recommendation. So it's not, does not affect mortality, but steroid reduces the ICU stay, not the hospital stay, reduce the amount of vasopressor needed, and reduce the days on mechanical ventilation. And the harm, there is no documented worse or adverse effects with use or severe adverse effect with use of steroids. Vitamin C is the last thing to go. The talk about vitamin C started in 21. One of the studies called the PROWESS study. And that study found that vitamin C has a mortality benefit. And especially they used Apache score, the ICU, more than 25. And they said, Apache score more than 25, you use IV vitamin C, that has reduced the mortality, and the number needed to treat is 8, which is great. And then in 2012, there is a browse shock trial, again, which came up with a different outcome. So they find that vitamin C has no effect on mortality, and it might have some harmful effect. And there was questions about the original study, which is the PROWESS study. Is it like a valid? Is it something flawed or not? So this is simply the updates. And the last one, part is the new section, the long-term outcome. And this is my summary screening. So I summarize all of these in these slides. Sorry for the quick talk. People who knows me, they are not used for me talking this fast, but we don't have time. And thank you, and I'm ready for questions if there's any.
الآن أعتقد Q&A session. If you have any questions, raise your hand.
كان هذا هناك إذا في questions من الزوم.
سؤال موجه للدكتور محمد عدوري. Can we give no adrenaline through IV line inserted in the dorsum of the hand, and for how much time?
معلش لأن الصوت راه ما نسمعش كويس، كان حد يعاود لي السؤال.
تمام. دكتور محمد تسمع فيي أكيد؟
كويس.
Can we give noradrenaline through IV line inserted in the dorsum of the hand, and for how much time?
Good question. It's so the recommendation in 2021 is to give it. It's better to be in a proximal vein, but it happened to me in my practice, even here in the United States. So some patients you can't have like ideal vein or big vein, proximal vein. And if the patient is shocked, I think I would go for it if the time is minimized. So, for example, if I'm gonna do that for half an hour, 1 hour, in the meantime, I'm gonna insert the CV line and send patient to the ICU, I would do that, but not for a long time. The recommendation is very clear. It's not for a long time. It has to be, they give 6 hours, but in peripheral small vein, you're gonna be like careful.
Thank you very much, Dr. محمد. في سؤال وقت آخر اسأله لو كان في أي quick survey غير Q SOFA في أجل recognizing sepsis.
Yeah, so in a Q SOFA, so in sepsis screening we have many scores. So the Q SOFA هي واحد منهم. يعني Q SOFA is one of them. We have a news اللي هي اللي National Early Warning Score, and we have a news which is modified. We may use in pregnancy and SIRS. So all of them has like pros and cons. They have advantage and disadvantage. So for me, I would recommend news in the ED, okay? And for the unexperienced, junior doctors who don't have much experience, I would recommend SIRS. And the reason why, because SIRS is very, has high sensitivity. And one of the problems with SIRS is I'm gonna classify people as septic and they are not septic. And this is, for junior doctors, I would recommend using this, but there is no right or wrong. So news, SIRS would be great, whatever you are comfortable with.
Thank you very much, Dr. Muhammad. Last question for you. If I suspect adrenal insufficiency history of adrenal problem with patient, should I give hydrocortisone directly without fluid bolus?
Yes. So if there is adrenal insufficiency, you're gonna treat adrenal insufficiency. So for example, if a patient has adrenal insufficiency, he is on chronic use of steroids, you're gonna use it. The second thing, if you have like strong clinical context of Addisonian crisis, for example, the biochemistry and everything is pointing toward it, and the patient is at risk, and that could be like chronic Addison disease and sepsis precipitating something like this, Addisonian crisis. So you go straight away and use steroid in patient who is suspected to have Addisonian crisis. ما اسمعش فيك دكتور، السؤال لي.
دكتور علي معيوب، بالنسبه للفوليوم ستيتس التارجت بتاعها في المانجمنت والسيبسس، في الترانسبراسيك ايكو to determine the volume status.
اوكي سو انا
فلويد او لا؟
فهمت عليك يا دكتور. Again, good question. Okay, so amount of fluid with fluid responsiveness هذينا kind of a matter of debate. لكن the fluid responsiveness, the recommendation, we have static like tests or static parameters, and we have dynamics. Like a CV pressure. CV pressure is something from the past, and we shouldn't use it to assess volume status. And it was part of early goal-directed therapy, but it is now not used. But you can use the other parameters, like the pulse pressure variation, the stroke volume variation, And even you can use the IVC. I saw somebody wrote in the chat box IVC. You can use your ultrasound and the IVC in intubated patient, mechanically ventilated patients. And no one of these tests is great. And you can use echo, the TVI, which is again using the straight leg, the straight leg raise test. So the straight leg raise test and use echo, straight leg raise test and use IVC, and use pulse pressure variation using the outline. All of these are parameters. Whatever you go with, you need to do many of them, maybe a couple of them, in order to come up with a decision or an assessment or clear picture of the volume status. So all of these. So short answer is dynamic test, echo is part of them. Static test, you don't use them.
السؤال الثاني دكتور mortality rate of sepsis in United States.
Again, good question. أنا مش هنعطيك رقم بس نقول لك moving from sepsis. Now sepsis تعريفه أنت عارف early sepsis, septic shock. ما عادش فيه الكلام ده. So moving from early sepsis to septic shock ما تاخدش عليه الرقم هذا, but it can reach up to 30%. And it's one of the biggest killer. And delay of every 1 hour, according to UK statistics, delay in 1 hour of giving antibiotic is going to cost you increase in mortality by 7.6, which is about 8. This is higher than the STEMI. You know, the door to needle time for STEMI and the door to needle time for sepsis. If you compare these two, so sepsis is going to be more than, the mortality with sepsis delay in treatment for antibiotic from sepsis is going to be more than delaying thrombolysis and STEMI.
Thank you, Doctor.